Okay, let's talk about how we apply this knowledge. And again, even if you're not managing the revenue cycle per se, I think you'll see as a clinical or operational manager where some of these things will touch you potentially. So, just to review quick, we've got our revenue cycle, you've got lecture notes on that, we've got reports to monitor the revenue cycle. Most important one, in my opinion, is denial authorization. Right here, it's like the blood test. We've got our accounts receivable. The concept of aging is crucial. We talked about payer mix. If certain payers pay higher than others, right, and you have a shift from a higher to a lower payer. We talked about days and receivables, average days and receivable, how long it takes on average to get paid. Talked about calculating that. We'll go back to our variance analysis, right? Review that. Favorable and unfavorable concepts relative to budget. And we can't just take things at face value. Talked about that. Again, why variance analysis. Talked about comparing percent changes to the drivers, the thing one, thing two drivers. My favorite, rate and volume variance quantified as to the actual amount, what's due to volume, what's due to rate. Okay, so let's we're going to do three case studies. One kind of I developed for the education purposes, and the last two are the real deal. So we've got Dr. Joint and Dr. Foot and Ankle. Where they don't, they're not too keen on budgets. They benchmark against prior year. That's fine. We've got some revenue variances. We've got some surgeries. They get paid per RVU. Workers' Comp and Blue Cross Blue Shield are the highest reimbursing payers. We hired a new billing manager and some new staff this year. So, Dr. Total Joint is happy. His revenue is up. Surgeries are up. Pretty happy. Dr. Foot and Ankle, she's really mad. Her revenue is down, and her surgeries are up. So, you look at this at the face value, I guess you can understand. But I hope we've learned one thing. We have to look beyond the face value. So, step one, we don't get paid by surgery, we get paid by RVU. So, let's look at some data here. RVUs, Dr. Total Joints RVUs are up 10.5%. So, if we just do this relative percent thing method, but his revenue's only up 5.3%, right? His rate per RVU is down. So, should Dr. Total Joint be as happy? Right? Maybe not. So, again, we looked a little deeper. Dr. Foot and Ankle, her RVUs are down 15%. Her revenue is only down 12.4. Her actual rate per RVU is up 3%. So we just flipped everything on its head, right? Maybe joint should be unhappy and foot and ankle should be happy, right? So the one thing I want you to know, and you're going to have this in the assignment, the physicians always love to blame the billing department. Sorry if there's any clinicians out there. It's my experience. If the issue is volume related, it's probably not the billing department's fault, right? If it's a rate per issue, if the rate is down, then you can start to look at the billing department. It's more likely. It's not definitive. So when you get a question in the final, absolutely the billing department's fault, don't fall into that trap. These issues are where to look, not place blame. It's where to start looking. So, I'm a big favor of the percent variance relative to drivers. That's what most people use. But you had my class, so you're gonna want those quantified because I really like rate and volume variance. So, Dr. Total Joints revenue variance is favorable, $165,000. The volume variance, $314,000 favorable. Because more RVUs. The rate variance is unfavorable. Okay, 149. Could be billing, could be something else. So we're not making definitive judgments, but again, the purpose of this variance is to tell me where to look. It's a toolkit. Where do I start looking? Dr. Foot and Ankle, the volume variance is unfavorable by 612,000. The rate variance is favorable. So I'm probably not going to be looking at billing for Dr. Foot and Ankle. I'm going to be looking at while these RVUs are down. So again, just to emphasize this, we look at this, we make some erroneous conclusions, we start digging a little deeper. We're getting we're starting to know where to look, get to the core of the issues. So, anyway, so step one, let's get the metrics. And again, since we're paid by RVU and not surgery, we got to get those RVU metrics. Step two, let's quantify the differences, right? In rate and volume variance is my preferred. Okay, step three, let's start looking. What might be happening? I always look to payer mix. Again, has the payer mix shifted from higher paying payers to lower paying ones? Okay, so we said workers' comp and Blue Cross pay better. Okay, so Blue Cross is it's down a little bit. Okay, workers' comp is way down. It's down 8% or 35% on a relative basis. Medicare is way up. So in Illinois, because the workers' comp fee schedule for surgical is typically the highest, again not for office visits, I can go ahead and try to quantify this, but I'm thinking the problem, this is a big clue. The payer mix has shifted. Now the next thing let's look at denials. Okay, so medical, not medically necessary, kind of went up. It's a 33% change. Okay, why are we getting those denials for not medically as a documentation issue? No referral authorization, up 400%. Okay, so he's doing the surgeries, but he's not getting paid. Okay, so some places the physician's secretary or administrative assistant might be in charge of getting those authorizations. Some you have an authorization department, but I can tell you right now, somebody is dropping the ball here. It's not billing. In When I started at this large orthopedic group, they had centralized surgical authorization, and I made it part of the physician's administrative assistant's job, and the reason is, and then just did a lot of training, and because it's really to know that physician's patterns and to know that physician and to work closely with that physician, and it was just easier to hold the people accountable when they had that direct one-to-one relationship with the surgeon as opposed to an amorphous group. You really get to know the physician and make that you're the person accountable for getting this surgeon's surgeries authorized. And this one of the reasons that this really the light bulb went off. We had a physician, that a spine surgeon, that literally lost $250,000 in revenue because the amorphous surgical scheduling authorization department, dropped the ball. Okay, timely filing up 150%. Okay, again, we're not focusing on the dollar variances. We're focusing on the percent changes. Okay, is Dr. Total Joint getting his operative reports done in time? Is the billing department waiting and waiting? And believe me, I've written I've had a number of talks with a number of doctors over my career where we had to write off the charges or collect zero because they didn't get their stuff done in time. Maybe their billing. That, once we wanted to elect EMR, electronic medical records, that really improved things. But it used to be they would just like have a notebook or something before we went EMR. So anyway, with Dr. Total Joint, I could quantify some of these things, but I can tell you definitively, even though it's a rate variance, billing is there's nothing to look at here with respect to this so far from billing. We've had a payer mix change from a higher paying payer to a lower. We've had a huge increase in no referrals. So it's either his secretary or the department is dropping the ball. There should that to me it's a never. It should never be a denial for no referral authorization. That is just a failure of the process, but it's not usually a process that resides in billing. Okay, now let's look at the aging accounts. The accounts are relatively older, so you see that these bars in the older accounts. Now I can start talking to billing about this if I want to quantify that in kind of a nice, neat number. Last year it took 65.3 days on average to get paid, the days in accounts receivable. Now we're up to 80.1, and you can see that kind of reflected in these bars. The percentage of accounts are relatively older, the blue bars being higher toward the later time period. So this is something. Now they say, look, it it might just because you're fighting on this no referral, we're fighting on medical necessity, et cetera, et cetera. But I'm going to have a talk. So again, there's no exhaustive thing here. The thing that I'm trying to emphasize is these reports are part of your toolkit. Now let's okay. So and with Doctor, I didn't really go into Doctor Foot and Ankle, but let's take a look here. Volume variance did more did more surgeries. Foot and ankle surgeries were up 6.3%. RVUs were down. Could be, foot and ankle. You go from doing a lot of total ankles to bunions. Maybe hand is, well, no, hand foot and ankle is fine. So you're doing less cases with less complexity. Okay, so this is not to be, again, this is, we're not making absolutes here. Between a rate and volume variance, it's more likely that there's a billing issue if it's a rate, and it's more likely to be an operational issue if there's a volume. Okay. Again, more likely, not definitive. So we saw that with based on the RVUs, there could be marketing. There's less RVUs. It could be someone isn't picking up the phone, and I mean, I had a marketing person who I wound up firing. They were in charge of the email when people, this is old school, when we just email, hey, I'm interested in seeing a doctor, I have a question, that contact us thing. And their job was to every day was supposed to go in there and then forward those requests to the, hey, I want to schedule an appointment with Dr. So and so, or do you have a doctor that does, whatever, does anterior hip approach for total joints, and and she was supposed to quarterback those things, hand them off, check the email every day, and I don't know. We found, I think, 6 months of she never checked for like 6 months. So volume, well, people, if you don't get a response to your email, maybe you go someplace else. Okay, so you've got to really get underneath there and dive below the surface. So operational phone, we just kind of covered this. The phones aren't being answered. We had a case where some billing person was, no, some not billing, some cu- uh, person in the customer service was telling people that we don't participate in United Healthcare. I, we, I don't ask me. We had a grid which said who we participated with, so eventually it surfaced. Why would you say we don't participate in United Healthcare when you have a grid that says we do? Welcome to management. Okay, so rate variance. Again, what I look at payer mix first. I look at denials and adjustment codes. Then I look at these days and things. Okay, that's kind of where I go if it's a rate variance. More likely to be a billing department, but as you can see with payer mix and denials, absolutely not always. Okay, so this is super relevant to your homework. Let's look at a real world case. This is what I would do with the physicians. The first thing I did, I met with them, or my team did. I developed a template. Tried to meet with them quarterly. That got just too much, but at least twice a year. And so the first part we would do some education, apparently just exactly like I just did to you. So we would present some education to them on collections. Let's look at your RVUs, basically a rate and volume variance, right? Because the first place, just like we did, physicians' collections are down. Are you doing less RVUs before we go there? And I think I told you the example earlier of the physician that was upset. Their collections were down. I pointed out they were, took a month off, were out of the country. They said they made up for it, but I did a rate and volume variance and they hadn't. So we had kind of covered this, but I'd give this example. I would explain to the physicians, this would be in their packet, that with respect to revenue cycle efficiency, everybody owns it, right? The front desk, the call center, your medical assistant, right? It's a cycle. It touches everybody. Payer rates, talk about denials, payer mix, etc. We've had the payer slow down the payment. We had a Blue Cross system we'll talk about in a second issue. Workers' comp, I think I talked about in the earlier lecture. I had to go to the legislature twice and testify and lobby. And we talked about payer mix, service mix. Are you doing less total joints, more knee scopes, et cetera, et cetera? So I'm educating physicians here on it's a complex thing. So this is literally something I would give the physicians when we met with them. Okay, so then I would just do a very kind of simple thing. I compare last year to this year, collections, RVUs, rate. I do a rate and volume variance. So in this example, this is a real life physician. The rate variance was significant. Why? And then I would kind of say to the physician, here's what we're going to look at. Days in AR. Why is it increased? These are huge relative to everything you've seen. At the time, the state of Illinois literally was taking 2 to 3 years to pay its bills. This physician had a lot of workers' comp. I've talked to you about the issues of workers' comp stopped paying because they could get away with it. Why do we have an increase? So I'm using the tools that we just discussed to quantify and then direct some things to the physicians. We would distinguish between hospital and office RVUs just to kind of bifurcate that. In this case, hospital really wasn't big enough change to worry about. Office, okay, whatever. But the collections again. So I would just basic setup the way we organized it. So again, we looked at payer mix and zero based account analysis. So one of the things I would do is we would look at the counts that have been fully adjudicated, so zero balance, just to get rid of any timing noise. And we would compare the rate per RVU by payer on fully adjudicated accounts, basically that whole date of service thing we talked about. And we would look at things to maybe explore. And these are actual notes, kind of by payer. Do we think it's better material? do we need to look at it, right? I don't see tremendous amount here. I mean, there's some high percentage things, but some of them are high percentage with low volume. Now, one thing, the percentage of claims adjudicated so far, that's kind of telling. If I'm doing apples to apples time periods, less less claims have been fully adjudicated for that time period, so that's kind of telling me something. Now I look at payer mix. I see that we've had an increase in litigated. They take a while to get paid. Workers' comp is down, so that's not good because, right, for this surgeon, this worker comp pays the most. So, Blue Cross, not too bad. Litigated, okay. But, I'm not seeing, I mean, that's not terrible, what I'm seeing here in the pair mix. Okay, so then what we looked at is kind of aging, and I compared last year to this year. So what I did is I looked at accounts over 90 days, and we see a huge increase in Blue Cross Blue Shield. And I remember this issue. Blue Cross Blue Shield, in its ultimate wisdom, put a new claim scrubbing system in, and that's a system that analyze. Now they would call it AI. A lot of stuff is being called AI that really isn't, but they put in a claim scrubbing system, a third party system that would analyze claims for various issues before it even got to them and into their main system. So in their wisdom, they automatically pended all. This system was set up to automatically pend any office visit with an X-ray. Okay, that may be fine for primary care, but for orthopedics, it's basically every claim, right? I mean, we're doing X-ray on almost every patient, right? Do you have a break? Do you have spinal stenosis? Is it healing? Right? Is it healing well? Right? You're in a cast. Is it healing? So they pended like 90% of our claims. And then they would ask for documentation. And we had to meet with them like, what do you mean? We can't give you documentation on every frickin' office visit. We're orthopedics. So that took a while to get worked through. This workers' comp increase, they weren't paying the claims, which led to the lobbying. Medicare, I don't recall why, but that's something we need to look into. United Health, why. So we would look at the differences in these aging. Remember, I said how important aging was. And then, so some of these things we knew, some of these things, we're going to ask farther or ask deeper. Okay, so this is literally what we would do at least twice a year for physicians. And again, we hit the high things. Pair mix. We didn't, if we saw more rate issues, we would look at denials. But generally, with denials, I looked at those every month with my revenue cycle manager, and rarely were they a big issue for us because I'm such a, you know, a fanatic about that. So we'll see a second real world case that my good friend Karen Zupko, who has a like the number one premier kind of boutique consulting firm on kind of physician practice management and coding. She was kind enough to let me use this, so thank you, Karen. So this I redacted. This is a real report I've extracted from university practice plan. Kind of the same issues I talked about the consulting study that I did. I could I could have used that, but Karen does much nicer graphics than me. So, best way to get paid: don't get denied. Document it the first time. So this is an excerpt from her report. Absolutely correct. Denials and write-offs. This is exactly what we talked about in the last class. Remember I said you could slice and dice those a variety of ways: by surgeon, by procedure code, payer, amount, percentage of claims. Denial reports, number one thing, love them. So what did she determine? These these are denials by physician. This is real money, folks. Now, it's amazing that Karen had to go do this analysis and this wasn't, regularly done. But that's why Karen has a hugely successful consulting firm, because people haven't taken this class and learned how to manage receive revenue cycle. So what she determined in her analysis: 34% of these denials, the documentation was requested, not provided. There was coding issues. There was no auth. Oh, that's a punch in the gut to have a no auth. It's just like a unforced error in tennis. It's like missing a 1 foot putt in golf. 6% registration errors, credentialing, duplicate claims. Okay, that's kind of okay. So let's talk about the slide I put up. Where do you look? Documentation, that's physician education. Coding, physician education. No auth, who's in charge of auths? Registration, get it together, folks. Credentialing, who's in charge of credentialing? Why isn't this done? Okay, cost of denial. This is just some expert. They requested information from regarding the surgery. 166,000. No payment because it was part of another procedure. Okay, that's kind of a coding issue. Payer said documentation didn't support, what was done. Probably a documentation issue. Provider not certified on the data procedure. Credentialing. Ugh. Throw away, throw away. Okay, altogether there was 2.5 million. And then she did some denial work by procedure code. These would have been paid if properly documented. Okay. Some other ones: no authorization. So they were spine and sports. Ugh, we already talked about that. Punching the medical necessity not documented. Past denial timely limit. Past denial filing limit. So they build past the contractual. Again, I said, like United, 90 days. Most of La Signa and these. So this is just unforced error, people. Okay, so opportunities, pre-auth, right? Look at your pre-auth procedures. Deeper look by surgeon. Mandatory education for spine coding and surgeons. Expand finding to other specialties. So she did sports and spine. So she's suggesting that they expand to the other specialties, because this is all fixable stuff. Documentation training is a must, right? You got to get that documentation done. So Karen, when I met her 40 years ago, it was Karen, and she did this coding education and documentation education. And because there was such a need for this, she's expanded, and is really the preeminent coding education for orthopedics, ENT, plastic. She's the go-to person. And we talked about this earlier. Establish a feedback loop. This is the same thing that I mentioned before with the very again a faculty practice plan. My report very similar to this, only not as pretty. There was no feedback loop, right, between the denial and back to the source to get the root cause of the issue and fix it. So again, thank you, Karen, for allowing me to use this data. So this is real world stuff, and if you're again you're managing a clinical department, some of these things are back to the clinicians or to the effectiveness of the operation department. It's not just the billing department. That's the takeaway here, folks. You can't just make snap judgments. You got to dig deep.